Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. Now, what's going on in this X-ray? Are you able to recognize what that arrow's pointing to? It's a pulmonary lesion of sorts. We're going to be discussing this and much more in this presentation on lung cancer pathology. This is covered in your book, Medical School Pathology and Step 1 Review. You can scan the QR code to get to the updated material, right? I'm here to make sure you succeed. Let me know if there's any way I could support you, or if you have any questions or concerns or comments, let me know. So let's talk about lung cancer. In the great US of A, lung cancer is the cancer that kills people most commonly. Key risk factors for lung cancer include cigarette smoke, radon exposure, and asbestos exposure. Because of the more than 60 carcinogens found in cigarette smoke, people who smoke account for 85% of lung cancer cases. So despite what your patient tells you, oh, doc, I need to smoke this cigarette because I'm stressed out, I need you to tell them, hey, you know there's an 85% chance that this lung cancer is going to affect you, right? We got to look out for our patients. So what is this lung cancer business? Well, particularly mutagenic substances in cigarettes include arsenic and polycyclic aromatic hydrocarbons. Now, all these chemicals can cause issues down at the cellular level, leading to cell cycle disruption and the promotion of mutagenic processes. Smoking duration and amount are directly correlated with the chance of developing cancer. And that's noted as pack years, right? You're going to see that a lot in the near future if you haven't already. Interestingly, the radioactive decay of uranium, which is found in soil, produces radon. Uranium accumulates in enclosed areas like basements. Uranium was actually identified to be the second most common cause of lung cancer in the United States and is responsible for the majority of the public's exposure to ionizing radiation. Uranium miners also have a higher chance of developing lung cancer. The non-specific symptoms of lung cancer include coughing, weight loss, hemoptysis, and post-obstructive pneumonia. The diagnosis of malignancy requires a biopsy, right? Some surgeon or specialist needs to obtain the tissue for the specimen to be sent to a lab, processed, put on a slide, and then the pathologist finally sees it and looks at it with their microscope or digitally and diagnoses benign or malignant, etc. Uses their immunohistochemistry or molecular markers as well to get at the specific diagnosis. But let's keep this simple for you right now, okay? Keep in mind that the diagnosis of malignancy requires a biopsy, even though the imaging frequently identifies a single nodule or a coin lesion, as you can see here in this accompanying CT scan image. A coin lesion can also be caused by benign lesions, which commonly affect younger patients. Examples of lung lesions include granulomas, bronchial hamartomas, lung carcinomas, including small cell carcinoma and non-small cell carcinoma. Now, since we're mentioning it, let's talk a little bit about those granulomas, okay? You remember that? Did you see that presentation already? Either way, be sure you can recognize the difference between a naked granuloma and a caseating granuloma. Now, what's the classic condition associated with naked granulomas? You would usually see bilateral hilar adenopathy, maybe an asteroid body, sarcoidosis, right? And what about caseating necrosis? TB, right? You will see those. But on the topic of lung cancer, keep in mind that granuloma should be on the differential, at least initially, before a definitive diagnosis is made. And in regards to that, a small area of inflammation is called a granuloma. It may be associated with necrosis or not. It may be naked or not. It may be caseating or not, right? You're highly likely to see giant cells forming. In the Midwest, granulomas are frequently caused by histoplasma or tuberculosis. Bronchial hematomas are benign tumors composed of lung tissue and cartilage, right? And lung carcinoma is a type of cancer that begins in the lungs. We're going to talk about specific subtypes in a minute, right? Lung carcinoma is classically divided into two broad categories, either small cell carcinoma or non-small cell carcinoma. Small cell lung carcinoma comprises about 15% of lung cancers and is a undifferentiated tumor made up of cells that look quite primitive, as you can see here on this H&E stain. Note all the basophilic small cells, basophilic meaning blue, right? Taking up the basophilic stain, right? This is small cell lung carcinoma. Small cell lung carcinoma is usually not amenable to surgical resection, so it's treated with chemotherapy. And here we have the imaging from a patient with small cell lung carcinoma. And here we have imaging from a patient with anaplastic, also known as microcellular or oat cell carcinoma from the lung, which is a type of small cell lung carcinoma. Small cell lung carcinoma should be distinguished from benign mesothelial cells, right? And we can see that with this FNA specimen. And here we have a very high power image of a small cell carcinoma that was obtained from pleural fluid. And here we have more FNA sample from a patient that has small cell carcinoma. Now you might be wondering what an FNA is, so let me explain that really quick. FNA stands for fine needle aspiration. This is actually a procedure that a lot of pathologists do. Those types of pathologists are known as cytopathologists. They tend to do procedures, they see patients and do aspirations with a needle, hence the fine needle. Usually it's more superficial, like a protuberant lesion on a knee or something in the axilla or in the neck region. If it's the thyroid or the lungs, usually there's some other sort of specialist there that did a residency in medicine and something afterwards like pulmonology or maybe some sort of surgery type of specialty. For example, if it's in the liver, if there's a lesion in the liver that a cytopathologist needs to look at, an interventional radiologist might do the biopsy. Either way, once the sample is collected, it's put on a slide and really quickly stained, and the cytopathologist looks at it and says if it's benign or malignant frequently on the spot. They come back later with more testing and a clearer diagnosis, but that's a whole rant. Takeaway, FNA, fine needle aspiration of some sort of lesion, okay? It's unlikely that you'll see it, so I'm going to just hit on the high yield things that you'll need to see and know and be familiar with. So what do you need to know from this? In the top right, and actually all of these, we have various examples of carcinomas of the lungs. So you should actually pause this and read the description, because there's a lot of high yield things that can come from this slide. But for the most part, be able to differentiate between small cell carcinoma and the other important carcinomas, which I'm going to talk about more so in depth right now, like non-small cell lung carcinoma, okay? Non-small cell lung carcinoma is the majority of the lung tumors, right? So we have squamous cell carcinoma. We have large cell carcinoma. And we have adenocarcinoma. Those are the other ones that you need to know. Now, approximately 85% of lung tumors are non-small cell lung cancers. And keep in mind that TTF, or TTF1 I should say, is a great marker for lung cancers. Now, non-small cell lung carcinoma does not respond well to chemotherapy. Thus, it is initially treated with surgical resection. To the right here, we can see an example of a non-small cell lung carcinoma at the microscopic level being stained with PD-L1 immunostain. That's important for pathologists and you future pulmonologists and hematologists, or anyone going into hem-onc or radiation oncology. You're going to want to know about PD-L1, but that's in the future. That's future you. Remember, I told you here first, PD-L1. But for everybody in general, in this particular moment, keep in mind that non-small cell lung carcinoma does not respond well to chemotherapy. So we use surgery for this. Subtypes of non-small cell lung carcinoma that you definitely must know about include adenocarcinoma. It will look glandular, okay? Squamous cell carcinoma, right? It'll look squamoid. Large cell carcinoma at the microscopic level has large cells. And neuroendocrine tumor, aka a carcinoid tumor. Now that has a very unique histologic finding called salt and pepper chromatin. You'll definitely see it, so I'm going to be sure to point that out for you later on. So there is a specific staging process that's performed on many different types of cancers, right? They use the TNM staging mechanism, and that stands for tumor node mitosis, so tumors like the size of it, and if there's any nodal involvement or any metastatic involvement, right? And this is done to assess how the prognosis is going to look like, okay? It's going to tell you a bit about the prognosis. T for tumor size and local extension can be observed as well. Adenocarcinoma is typically associated with pleural involvement. For example, superior vena cava obstruction results in a condition that you must know about, okay? Superior vena cava obstruction results in an enlarged head and neck veins, edema, blue coloring of the arms and face, and this is called superior vena cava syndrome. Highly likely that you will see that. Involvement of the recurrent laryngeal or phrenic nerve often occur as well, so that patient might have hoarseness or trouble breathing. Horner syndrome is caused by compression of the sympathetic chain. Symptoms of Horner syndrome include ptosis, drooping eyelids, miosis, pinpoint pupils, and anhidrosis. Pancoast tumors may cause Horner syndrome. And take note, the adrenal gland, for some reason, is a distinctive location for distant metastasis. Overall, the 5-year survival rate for non-small cell carcinoma is only 15%. As a result of the lack of a reliable screening procedure, non-small cell carcinoma frequently manifests late. So let's talk a bit about adenocarcinoma of the lung. Adenocarcinoma of the lung is composed of glandular cells, okay? If a non-smoker has lung cancer, it is likely adenocarcinoma of the lung, contrary to squamous cell carcinoma. With squamous cell carcinoma, we usually see those in smokers. To the right here, we can see an H&E representative section from a patient with bronchoalveolar cell adenocarcinoma of the lung. Adenocarcinoma of the lung tends to be peripherally located. And here we have more H&E of an adenocarcinoma. Note the lipidic predominance of its architecture. And for this, just be aware that lung adenocarcinomas have glandular features. And remember, TTF1 is a good marker for staining lung cancers, just in general. And just to reiterate, remember the glandular formation for lung adenocarcinomas. Now let's talk about something that smokers are more prone to get: squamous cell carcinoma of the lung. Now, squamous cell carcinoma of the lung is typically centrally located. Squamous cell carcinoma of the lung is more common in smokers. Okay, that was easy. Now let's talk about large cell carcinoma of the lung. Large cell carcinoma of the lung typically grows rapidly, fast, accelerated, quickly. Large cell carcinoma of the lung spreads aggressively. Here we have an H&E section from a patient with large cell carcinoma of the lung. And here we have a gross representation. Gross means like you're just there looking at it in person, of a patient whose lung was removed and has this massive protuberant white growth, large cell carcinoma of the lung. And here's another section, grossly, from a patient with large cell carcinoma of the lung. And here's what it looks like at the microscopic level. But these are different carcinomas, so you're going to want to pay attention to this one, right? We have small cell carcinoma of the lung in A, large cell carcinoma of the lung in B, squamous cell carcinoma in C, and adenocarcinoma in D, right? So of those, which one looks more glandular? D, right? Adenocarcinoma. Which one looks more squamoid, more cohesive, more stuck together, kind of like the skin? C, right? squamous cell carcinoma. In A, what type of carcinoma is that? Small cell, right? And in B, we have large cell carcinoma. Now let's move on to a highly tested lung cancer known as neuroendocrine tumor of the lung. Now this is obviously composed of neuroendocrine cells, right? The histology, which you must know for neuroendocrine tumors of the lung, shows unique cells with salt and pepper chromatin. And here you can see that the arrows are pointing at mitotic figures, but the majority of other cells, note how they look like circles, and in those circles there's this like gritty white and blue sort of material. That's that quote unquote salt and pepper appearance of the chromatin. And neuroendocrine tumors stain in general positive for synaptophysin. You're going to have to know that, right? So take note of that. Write it down somewhere in your book. Neuroendocrine tumors stain positive for synaptophysin, as well as, I'm going to give you some high yield stuff here. Don't tell anybody. Neuroendocrine tumors stain positive for synaptophysin, chromogranin, right? As well as CD56. But don't tell anybody I told you that. Now it makes sense. You're probably wondering, what? This doesn't look like salt and pepper? I don't want to hear that anymore, because right here, you can clearly see that neuroendocrine tumors look like salt and pepper. Okay? Got it? You made the association? You're never going to get this wrong. Next time you see this, give me a holler. Let me know. You send a comment. I want my props. Now, let's look at this cross-section on H&E. You see that? This is just another representative section from a lung cancer. But particularly in B, you can see high power magnification with tumulates with the neuroendocrine growth pattern. And unfortunately, these tumors can metastasize like all other like a lot of other malignant tumors. But take note of the necrosis that's happening within this lymph node. And with that, I want to remind you to give me my props, right? Because you're never going to forget salt and pepper chromatin for neuroendocrine tumors. If you do, I will be so disappointed. But I have faith in you. I have faith in your mind. You're smart. You're going to do me proud. Keep up the good work. If you have any questions, comments, or concerns, let me know. Until then, I'll see you next time.